Hi class, welcome to the online session. We are going to finish all the endocrine slides for today. We have a total of 7 slides. We have slide 171, this is simple goiter. We have 172, Hashimotos, thyroiditis. We have 175, that is follicular adenoma. 240, that's follicular carcinoma. 239, papillary carcinoma of the thyroid. 178, medullary carcinoma of the thyroid. And 169, Pheochromocytoma. Okay, so let's start with slide 171. This is simple goiter. So simple goiter is it can be sporadic or it can be endemic. And when it is sporadic, it is a female predominance. Okay, so in clinical practice, I see a lot of females, okay, those with goiters who are mostly females, okay, and then a few would be males. And then endemic goiter would be associated with iodine deficiency in the area, so usually they are in the highlands. And because of the endemicity, because of the iodine deficiency, there's tendency to cause TSH stimulation with resulting hyperplasia of the thyroid follicles and hypertrophy. Okay, but vast majority of our patients, when they have gone to our clinics, they would present with euthyroid goiter. It means that their thyroid hormones are normal. Okay, so histologically, when we look at the slide, you can see the presence of the follicles to be variegized. Okay, so you can have small follicles, large follicles, very large follicles. So you can see some to be very, very large. Here you can see areas of hemorrhage, and in some areas you would take note the presence of fibrosis, a presence of inflammatory cells, and then you would see the presence of hemosiderin-laden macrophages, lymphocytes, because some of the follicles tend to leak some of the colloid and would cause the reaction. So within some of the follicles, you see the presence of these hemosiderin-laden macrophages and lymphocytes. Okay, so this is a simple goiter. I'll just show to you the other areas. So you have some pseudopapillary formation. Usually we take note of the presence of secondary colloid formation to distinguish it from a papillary carcinoma. Okay, so you have secondary colloid formation within those papillae or papillary areas. So this is simply a papillary hyperplasia. Okay, next we go to slide 172, which we have taken it up during our diseases of immunity. So this is Hashimoto's thyroiditis. Hashimoto's thyroiditis, if you remember in the hypersensitivity reactions, they would be classified as type 2 because of the presence of antibodies against what? Against the TSH receptor, TSH thyroglobulin, as well as the thyroid peroxidase. And it is also a type 4 because it will have a cell-mediated immune reaction wherein lymphocytes are present in the areas, and this is associated with a gene polymorphism towards CTLA4 and PTPN22, which would cause the cellular response, the T cell response. So this can also be associated with other autoimmune diseases, like patients can also present with type 1 diabetes mellitus or other endocrine abnormality. So histologically, we would see the presence of thyroid tissue destruction, characterized by presence of lymphoid follicles in the area. We have to look for a thyroid follicle. This one. Okay, so we see a thyroid follicle here. Okay, so this is a thyroid follicle, and then you see a lot of inflammatory cells, mononuclear cell infiltration, areas of fibrosis, like in this case, because of the tissue destruction. And then with regards to the follicles here can present as atrophic or as metaplastic. Okay, so when you see atrophic, it means that the follicles would be lined by cells that are larger than usual. Okay, so these are the cells that are metaplastic. They would possess a larger round nucleus, and then they have granular cytoplasm. These are what we call as Hürthle cell. Okay, but in some of the follicles, like this one, okay, so the cells here, they are regular looking, but they are flattened. Okay, so that's a sign of atrophy. So when you see that the cuboidal cells are flattened already, so it's a sign of atrophy. Okay, so this is Hashimoto's thyroiditis. Okay. Next, we have slide 175. This is follicular adenoma. Okay. So take note that we are in the thyroid gland. So you always would see the presence of thyrocytes. So what is a follicular adenoma? Follicular adenoma is a nodule that would be benign. It's encapsulated, so we always would check for the presence of the capsule. Okay? Like in this case, you have a capsule, and it would be composed of follicles, okay, that are lined by thyrocytes. So you see here the presence of normal looking thyrocytes. Okay? Although we do not see the characteristic colloid within the follicles. Okay, so you can see the presence of the lumen, but there's absence of the colloid. Okay, so they are normal looking. Okay, they look like the normal cells, the normal thyrocytes, but this is identified by the presence of encapsulation. So this is a thyroid follicular adenoma. So some cases would present with toxicity in toxic adenoma, and we would see mutation towards TSH receptor or with GNAS mutation, leading to symptoms of hyperthyroidism and presence of fat nodules or imaging. Although in clinical practice, majority of the cases that we have would be non-toxic. Okay, so again, you have to evaluate for the integrity of the capsule, because this is a differentiating factor from follicular carcinoma. Okay, so if you would see the presence of invasion, okay, invasion into the capsule, or you can see here the presence of some vascular channels, the presence of vascular invasion, then it's follicular carcinoma. So our next slide is what we are talking about. This is follicular carcinoma. So in the cases, it represents around 5 to 15% of the total population of thyroid malignancies. If you're going to look at this particular area, okay, so it is indistinguishable from our previous slide, which is the follicular adenoma. So you would see the presence of normal looking thyrocytes, okay, with uniform round nuclei. They are forming follicles, okay. So they are cytologically indistinguishable from a follicular adenoma unless we would see the presence of marked atypia, okay. Um, then here you would see the presence of areas of hemorrhage. So now you would be thinking maybe this is something else, okay. So next you look at the integrity of the capsule, which is what we have, what we performed with the follicular adenoma. So here you would see the capsule and notice that there's a follicle, but in this instance it's there's absence of any similarity with the one below. Here's another one, so you would be suspecting. And then here, if you look at the bigger picture, there's already a nodule outside of the capsule, and this is already follicular carcinoma. So capsular invasion, and then you look for another criteria, which is vascular invasion. So you can see here the presence of some of the blood vessels, vascular areas. So you look for presence of cells, thyrocytes within the lumen. There, you would see the presence of a thyrocyte follicle or cluster in the lumen. There, okay. So this is a sign of vascular invasion. So capsular and vascular invasion would be the criteria for follicular carcinoma. Environmental factors, similar to follicular adenoma, it can be associated with deficiency of dietary iodine. The mutations here would be different from papillary carcinoma, wherein we have RAS, PIK3CA, PTEN, and some of the carcinomas would present with the fusion gene, which is the PAX8 PPARG. This is seen in 1/3 to 1/2 of cases, although 10% of cases of follicular adenomas can present with the PAX8 PPARG fusion gene. Okay. Next we have slide 239, which is a papillary carcinoma. Okay, so papillary carcinoma is the most common form of thyroid malignancy, representing around more than 85% of cases. It has an excellent prognosis of more than 95% in a 10-year survival rate, although there are prognosticating factors that would factor in, like age of being older, presence of an extrathyroid manifestation, okay, or distant metastasis. So this particular tumor is associated with RET, NTRK1, BRAF mutation, and environmental factor, if there's ionizing radiation exposure to the neck area. So histologically, we would see the presence of the papillae. Okay? So you would be able to identify that it's a papillae if it's forming papillary structures, and there's the presence of a fibrovascular core at the center. Okay, so this is a papilla, okay, with a fibrovascular core, fibrous, and presence of capillaries. So look at the nuclear feature of the cells. Okay, so this one would show the presence of an optically clear nucleus, and this is what we call as orphan Annie nucleus, okay, or orphan Annie nuclei. So optically clear nuclei. This would help us distinguish it from follicular adenoma or follicular carcinoma, because we have a follicular variant to a papillary carcinoma, wherein we do not see the presence of the papillae or papillary features, only the presence of follicles. Okay, so but if you see the presence of this this characteristic nuclear feature, which is called the orphan nucleus, then this would fall under the papillary carcinoma lesion. So you look at the other areas. Okay, so you have the papilla or papillae. Okay, another feature that we can associate with papillary carcinoma would be the presence of samoma body, but this particular slide doesn't show the samoma body. Okay, so remember, I think maybe this is one of the samoma body. Okay, this is not the samoma body. Okay, so this would remember the spelling of samoma body: PSA double MO double MA. Okay, am I correct? You just check. Okay, double MOMA. Okay, so next we have medullary carcinoma, which is 178. Okay, so medullary carcinoma, in the book it says it is seen in less than 5% of cases of thyroid malignancies, in 5% of cases, and anaplastic carcinoma would be less than 5%, although it's the other way around in my clinical practice. I see more cases of anaplastic carcinoma here in Davao City than medullary carcinoma, even in my residency training in Manila. Okay, so it's associated with RET mutation, and we would see the presence of C-cell hyperplasia. The C-cells here are round to spindly in character, and we see the presence of amyloid deposits here. So sometimes the C-cells would be seen forming follicles, even follicles. It can be seen forming nest or trabecular sheets. Okay, so like in this case, it's a pseudo follicle. Okay, because it's surrounding the amyloid. Okay, so the cells here would have a salt and pepper chromatin pattern, which is characteristic for a neuroendocrine tumor, and this would show C-cell hyperplasia. The C-cells here would secrete calcitonin, which is the tumor marker that we use. 70% would be sporadic and 30% would be familial. Okay, so here you would see the presence of the amyloid. Okay, so next we have the Pheochromocytoma, which is slide 169. Okay. So slide 169, we have Pheochromocytoma. Pheochromocytoma is derived from the adrenal medulla, and this would be composed of chromaffin cells. With regards to Pheochromocytoma, remember the rule of tens, wherein 10% would be extra-adrenal, 10% are malignant, 10% of sporadic cases are bilateral, and 10% do not have hypertension. Okay, so of course you have to look into the majority of cases. 90% would be found in the adrenal medulla. 90% are benign. 90% would present with hypertension. So that's the clinical finding that you would always look for. These patients have hypertension with irregularity in the rise of the blood pressure, and they can present with palpitations. Okay, so genetic mutations, we have different genes that would be affecting familial forms or familial syndromes. If it's part of the MEN2A2B, then it is RET. If it's associated with neurofibromatosis syndrome, then it's NF1. If it's associated with renal cell carcinoma, it's VHL. If it's associated with familial paraganglioma, it's with the SDHD, SDHC, or SDHP. Okay? So, with regards to identification of whether it is malignant or benign, only a metastatic lesion would be a reliable indicator of malignancy. Okay, so if we would see the presence of large nuclei, presence of mitosis, those are not reliable features. So histologically, what we would see would be the presence of chromaffin cells. So they are seen forming Zellballen clusters. Okay, so these are the Zellballen clusters. The cells here are would have round dark nuclei with pink cytoplasm. So these cells would have sometimes would also present with a salt and pepper chromatin pattern. They would have they would elaborate catecholamine. Okay, that would be epinephrine or norepinephrine. Here you would sometimes see the presence of abnormal nuclear formation or irregularity of the nuclear membrane. So this can still be part of a benign lesion. Okay. So this is Pheochromocytoma. Okay, so that's all, guys. So I hope you learned something today. So stay safe and good night.